Hi everyone, hope you are all doing good. Now we are going to discuss about the same topic, that is endocrinology in pregnancy. But in this topic we are going to see how the placenta is going to act as an endocrine organ, what is its role and what are the changes that happen in the endocrine organs of the mother. Okay. First, we will see the placenta. Now, placenta is a unique endocrine organ that is going to be only a transient organ. It is involved in the exchange of substances between the mother and the fetus. Also, this brings about immunotolerance in the mother so that her immune system is not acting against the fetal and paternal antigens. Okay. In spite of this, it produces various hormones whose roles may involve like maintaining the pregnancy, bringing about the maternal adaptations needed for pregnancy, it helps in fetal growth, and also they are necessary during parturition, that is during labor. Okay. Now we all know placenta is formed by decidua, bacillus and trophoblast. Okay. So, the trophoblast is differentiated into cytotrophoblast and syncytiotrophoblast. Okay. But if you see, the primary cell is only cytotrophoblast. From this only syncytiotrophoblast arises, and also the cytotrophoblast is going to differentiate into endovascular trophoblast and interstitial trophoblast and endoglandular trophoblast. Okay. So, endovascular trophoblast is going to invade the maternal blood vessels. Interstitial trophoblast is going to invade the uterine stroma, and endoglandular trophoblast is going to invade the uterine gland. Okay. And remember, cytotrophoblast is going to be made up of single cells with individual nuclei. Whereas syncytial trophoblast don't have any regular cell borders and it is multinucleated like this. Okay. So, among this, syncytial trophoblast is considered to be producing most of the hormones. However, also the other types of trophoblast are also seen to produce hormones. For example, if you take the endovascular trophoblast, for blood vessel invasion and angiogenesis, it has to produce hormones. Okay. Now, we will see what are the placental hormones. Placental hormones can be broadly classified into the various hormones include hypothalamic like hormones, okay, corticotropin releasing hormone, thyrotropin releasing hormone, which is TRH, then gonadotropins releasing hormone, growth hormone releasing hormone. Okay. Then some of the hormones are seen to function like pituitary. So, pituitary like hormones include human chorionic, gonadotropin, human chorionic, somatomamotropin, or this is also known as human placental lactogen, okay, HPL or HCS. Then human chorionic thyrotropin, okay. Then it secretes some steroid hormones as well. We know about this already. Those include estrogen, progesterone and yes, corticosteroids. And there are some growth factors also being produced by the placenta, and those include transforming growth factor beta, insulin like growth factor 1 and 2, epidermal growth factor, vascular endothelial growth factor, placental growth factor, then some of the other hormones like placenta specific beta 1 glycoprotein, placenta associated plasma protein A, even prolactin and other hormones like relaxin, early pregnancy factor, even atrial natriuretic peptide, etc. Okay. So, these are the various placental hormones. Now, we will see the important hormones one by one. First one, we will see about human chorionic gonadotropin. Okay. It is human chorionic gonadotropin. Okay. If we see human chorionic gonadotropin, this is a glycoprotein produced by syncytial trophoblast. It consists of two subunits. One is the alpha subunit and another one is the beta subunit. Alpha subunit is coded on the chromosome 6 and beta subunit is encoded on the chromosome 19. Okay. If you see alpha subunit, it is almost having similar action to luteinizing hormone, follicle stimulating hormone and thyroid stimulating hormone. Whereas beta unit is specific to human chorionic gonadotropin. Okay. It is also considered as a luteotropic hormone because it is closely resembles the function of luteinizing hormone both chemically and functionally. So that it is maintaining corpus luteum till placenta is taking over. Molecular weight of HCG is 36,000 to 40,000 kilodaltons, and this has a T-half between 36 hours. Okay. Now, we will see the various functions of human chorionic gonadotropin. Number 1, it is going to maintain corpus luteum and helps in secretion of progesterone by the corpus luteum and thus brings about uterine quiescence. Uterine quiescence means the uterus is going to be quiet. Okay. So, it is going to be relaxed and the contractions are inhibited. Okay. Also, the other hormones like relaxin is also stimulated by HCG. HCG provides an immunosuppressive effect. HCG is HCG causes testis differentiation. Now, how it causes testis differentiation? Because already we know HCG is closely resembling luteinizing hormone. What is the function of luteinizing hormone normally? It is going to act upon the testis to produce testosterone, right? Now, we all know that the male gonads differentiate early weeks itself, right? Like 7 to 8 weeks of gestational age. So, during that time, the fetal pituitary is not active. Okay. So, when does the fetal pituitary is going to get activated? It acts only from 12 weeks of gestation. But this testis differentiation is happening by 7 to 8 weeks itself. Now, who is bringing this differentiation? Yes, it is the HCG hormone because it is closely resembling the luteinizing hormone. Understood? So, by the time with the help of testosterone, male external genitalia differentiation is also brought about by this hormone. Okay. Also, know that what is the other hormone it is closely resembling? Yes, it resembles the thyroid releasing hormone also, right? Now, this is going to act on the mother, okay, act on the thyroid gland of the mother, okay, and since it is going to act on this thyroid gland, of the mother, this is going to produce a transient state of thyrotoxicosis in the mother. Okay, so that is known as gestational thyrotoxicosis. Also, we have seen this is going to bring about the maternal and fetal steroidogenesis. Understood? So, these are the most important functions of the HCG hormone. Now, we will see how the levels of HCG hormone are there, okay, throughout the pregnancy. So, initially HCG hormone protection starts by 8 days after fertilization or day 22 of the cycle, or it can also be said as day 5, it is 5 days before her expected menses. Understood? So, basically this is considered like if the woman is having a regular 28-day cycle. Okay, all these days are same only. Understood? And it peaks around some 60 to 70 days of gestation. In other words, we can take it around some 8 to 10 weeks of gestational age, okay, and then it starts declining around 16 to 20 weeks of gestation, okay, and it becomes a plateau level till delivery, and after delivery this will be cleared from the bloodstream within next 24 hours. In another 24 hours or 2 days. Understood? So, if we draw a chart for this, So, I am going to keep the gestational age in weeks down and the HCG hormone levels in international units per ml here. Okay. So, the production is going to start by 8 to 9 days of gestational age. Okay. This is going to start increasing slowly and by 10 weeks. Okay. So, this is around 10 weeks. Okay. It is going to reach the peak levels where it will be between some 100 to 200 international units per ml. Okay. Then it is going to decrease slowly starting from 16 weeks to 20 weeks. Okay. If you want to choose a best answer, you can choose 16 weeks, and this is going to remain in the plateau level itself till delivery, and after delivery it will take another 2 more days, okay, after delivery to clear it from the bloodstream. Okay. So, this is how the hormone HCG is going to be in different stages. And now we will see what are the various conditions causing changes in the HCG levels. Okay. So, HCG levels, it is increased in multiple pregnancy, choriocarcinoma, and trisomy 21, which is nothing but Down syndrome. Then it is also increased in erythroblastosis, fetalis, and hydatidiform mole. Yes, it is reduced in conditions like abortion and ectopic pregnancy. Okay, and you can also tell other trisomies, okay, like 18 and 13. Okay. Now, basically beta HCG hormone is going to show doubling activity. That means the hormone is going to increase by 33% of its previous value in another 24 hours. Okay, in another 2 days or 24 hours. Understood? Okay. Now, we will see a case scenario like a woman comes with a positive urine pregnancy test. No scans done. Okay. Now, you have to evaluate her using blood test alone. Okay. Obviously, we will be doing HCG hormone levels. Okay. Now, we will see a case scenario. For example, a 22-year-old female comes with a urine pregnancy test positive. Okay. USG done shows no sac. Okay. For example, in abortion, what is going to happen? HCG levels are going to reduce or they are going to be in a decreasing trend. Okay. When there is a ectopic pregnancy, there can be increase in HCG values, but remember this increase will be only about 10% increase. Okay? But what about intrauterine pregnancy? When there is an intrauterine pregnancy, what is going to happen? This will show doubling. So, day 1 HCG done and day 3 HCG done. So, this is all about HCG hormone. Now, we will see human placental lactogen. It is also known as human chorionic somatomamotropin. This hormone is a peptide hormone that is produced by syncytial trophoblast. It is produced at a rate of 1 gram per day at term, and the rate of production is directly proportional to the placental mass. Okay? For example, production starts around 3 weeks of gestational age and it keeps on increasing till pregnancy as the placental mass is increasing, and by 36 weeks of gestational age, this attains its peak levels. Understood? Now, what are the functions of this hormone? The most important function is this hormone is having anti-insulin effects. Okay, and this anti-insulin effect is going to reflect in the mother. Okay, so basically what is happening in a cell? Suppose if we consider the cell, insulin is going to push the glycogen inside the cells, right? But in pregnancy there is anti-insulin effect. So, whatever carbohydrate the mother has consumed, it is going to stay in the blood vessels itself. Okay. Now, as it is staying in the blood vessels, this is going to the fetus via the uteroplacental circulation for the fetal growth and development. Okay, because this glucose can't enter the cells because there is insulin resistance. Okay, there is a state of insulin resistance and this is brought by the hormone HPL. Now what happens is, we all know now that normally pregnancy is a diabetogenic state, right? Since there is insulin resistance, there is a state of postprandial hyperglycemia, and even when the mother is fasting, this carbohydrate extraction by the fetus is not going to stop. Okay, because fetus generally has a low level of glucose storage. Okay, so it is going to extract carbohydrates every time from the mother. So, whenever she is fasting, she will go for a fasting hypoglycemia. Okay, and this insulin resistance becomes more after second trimester, say after 20 weeks of gestational age. Okay, so that is why most of the GDM test will do during this time. Okay, and also the insulin that is left unused, okay, brings about a state of hyperinsulinemia, and this is going to cause increased fat storage in the mother. Okay, so whenever the mother is having any lack of energy, this fat deposits, okay, say free fatty acids, are going to be used as an energy fuel. Okay. Now, suppose if the mother is starving, okay, or if there is any hyperemesis gravidarum state, in this condition, there is more vomiting and more energy loss. So, free fatty acids are used excessively, that leads to increased ketone production, which is going to cross the uterus and affect the baby. So, it is basically going to harm the fetus. Okay. We will see some of the other hormones. Say progesterone. We have discussed many things in the previous session itself. So, only point I want to add is the production rate at the term is 250 milligram per day. Okay. And remember, there is placental aromatase enzyme that is helping in the conversion of androgens to estrogens. Okay. When this aromatase enzyme is deficient, this leads to increased androgens in the mother, which can affect the baby also. So, basically there can be hirsutism in mother and ambiguous genitalia in the fetus. The level of estrogens are reduced in conditions when there is anencephaly or intrauterine demise or in Down syndrome, and it is increased in conditions like erythroblastosis fetalis and maternal androgen producing tumors. Okay, so what happens here? Androgen is going to convert into estrogen, and hence by aromatase enzyme, and hence the estrogen levels are going to increase. And about progesterone, one point I want to add here, that the rate of progesterone production at term will be around 250 milligram per day. Okay. So, otherwise estrogen and progesterone have been dealt in detail in the previous chapter. So, we will go to the other hormones now. Okay. We will see placenta specific beta 1 glycoprotein. This is produced from 18 to 20 days after fertilization. This has immunosuppressive effect and it protects the conceptus. Next hormone is early pregnancy factor. Early pregnancy factor is produced by the maternal ovaries and the fetal platelets. Okay, and this is also seen as early as 6 to 24 hours after implantation, and this also has a immunosuppressive effect. Insulin-like growth factor is important for growth and development of fetus. And then corticotropin releasing hormone released from the pituitary actually till term this hormone, okay, see this is the corticotropin releasing hormone, it is bound to binding proteins till delivery. At term what happens is this binding proteins level decrease and CRH is going to freely pass through the placenta and reaches the fetus, and it stimulates the fetal HPA axis, and this is one mechanism initiating labor. Vascular endothelial growth factor is responsible for angiogenesis in first trimester, and placental growth factor is responsible for angiogenesis in third trimester. Soluble FMS like tyrosine kinase is going to antagonize this action. So, this hormone can be taken as a marker in preeclampsia. Another hormone is pregnancy associated plasma protein A. Okay. So, this is a key regulator in insulin-like growth factor activity. Okay. So, basically low levels of PAPA is seen when there is a risk of preeclampsia and also it marks poor growth and development of fetus in second trimester. Now we will see the changes in the endocrine organs happening in the mother. Number 1, we will see the changes in the pituitary gland. Okay. Pituitary gland increases by 30 to 50% in weight. Okay. Mostly this increase in the weight of the gland is brought by the hyperplasia of the acidophilic cells of the anterior pituitary. Now, as the gland is going to increase, okay, let us consider this as the pituitary gland, okay. Now, this gland has increased. Now, also for the growth of the gland, okay, the vascular supply will also increase, right. So, if there is any condition like say a severe PPH is happening and there is more blood loss, okay, and hypotension in the mother, that will lead to infarction of the gland and pituitary necrosis also, that can result in one type of syndrome called Sheehan syndrome. Okay. Now this syndrome is characterized by lactation failure. There is secondary amenorrhea, loss of libido, breast atrophy. There is loss of axillary and pubic hair, and also the women can present with signs of premature aging. Okay. Regarding the hormonal changes of the pituitary hormones, already we know follicle stimulating hormone and luteinizing hormone are going to decrease in levels because there is an increased level of estrogen and progesterone, and then there is an increase in hormones like corticotropin releasing hormone, okay, serum, prolactin, growth hormone, and adrenocorticotropic hormone, okay, whereas thyroid stimulating hormone remains normal, okay. Now we will see the next endocrine gland, thyroid gland. Thyroid gland also enlarges in pregnancy. Regarding the hormones, total T3 and T4, and also remember, due to the enlargement of the gland, the optic chiasma can get compressed and it can result in bitemporal hemianopia. Okay. Now we will see the next gland, thyroid gland. Thyroid gland goes for enlargement, and regarding the hormones, total T3 and T4 increases, whereas free T3, T4 and thyroid stimulating hormone levels are within normal limits. Okay. Also, serum iodine levels are reduced due to two reasons. Okay. Number one, there is renal excretion of the iodine that is increased, and there is transplacental transfer happening to the fetus. So, serum iodine levels should be supplemented at a higher dose, say 100 to 200 milligrams per day. Okay. Also know that basal metabolic rate increases by plus or minus 25% in pregnancy because there is an increased demand of oxygen in both mother and the fetus. And then the drugs given to treat hyperthyroidism in mother is going to cross via the placenta and it is going to affect the fetus. The same way for fetal brain development, okay, thyroid hormones are important, but the fetal thyroid gland is functional only by 12 weeks of gestational age. So, till then it is the maternal thyroid hormones that are going to maintain the neural development in the mother. Okay? Yes? I hope you would have understood. Next, we are going to see about the parafollicular cells. They also go for hyperplasia and increased calcitonin levels are seen in pregnancy. Next is about pancreas. Pancreas, there is hyperplasia of beta cells. So, already we know there is a state of hyperinsulinemia in pregnancy, insulin resistance in pregnancy, which will lead to maternal hyperglycemia, and this happens especially in the second half of pregnancy. So, basically the adverse effects of hyperglycemia is not seen in first trimester. Okay, adverse effects like any congenital anomalies due to hyperglycemia is not seen in first trimester. That means, if the mother is GDM, that is, she has developed the diabetogenic state only due to pregnancy, then she will start her symptoms by second trimester only. So, by this time, the fetal development of important structures would have happened and there is no congenital anomalies in GDM. Okay, but when there is a over diabetic state, okay, like previously itself she is a known case of type 1 or type 2 DM, then that can result in congenital anomalies. Okay, we will see about adrenal cortex. Adrenal cortex, slight enlargement of the adrenal cortex occurs. There is thickening of zona fasciculata also. Hormones are increased, especially the cortisol, ACTH, aldosterone, and to a minor levels testosterone and androstenedione also. Now, cortisol is a hormone that can travel to the placenta. So, pregnancy can also be considered as a state of hypercortisolism because there is reduced clearance of cortisol in pregnancy. Plasma half-life of cortisol also is increased. A few words on parathyroid gland also. Hyperplasia of parathyroid gland occurs. We know the main function is to regulate renal synthesis of 125 dihydroxy vitamin D3 and mobilization of calcium from the bone. Now this calcium is freely transferred across the placenta. So what happens is total serum calcium levels fall, but ionized calcium levels are unchanged. With this, we are completing endocrinology in pregnancy. Until we meet in the next video, happy learning, keep going and take care.